afternoon. Welcome to an amazing show, Ditokello Tsa Hao. I'm your amazing host, Tshepo Ngoato, and today we're going to be talking about sexual reproductive health. And we've got two wonderful guests here who are with us today, who is Sesona and Tanya. And before we get to them, please make sure and follow us on our social media platform on Senec_trust, and also simply go to our call to action number 067-267-3103. And today's topic is a very sensitive topic because we know that there's a lot of people who are against it and some issues that some people are supporting it. But I think it will also be best that we really unpack that discussion and some of the research literally comes with it and how we can be able to strengthen our South African society. And how are you?
Amazing.
First of all, it will be great that if you guys can introduce yourself. Who are you? Where are you from? And what do people know about you guys?
I am Sesona Buyeye. I am the communications assistant at Reproductive Health. It is a global research organization that conducts, we work with partners all over the world, and we conduct very rigorous research that impacts positively on the sexual and reproductive rights and health and lives of people. And we do so by using our research to inform some of our advocacy efforts. And I'm just going to let my colleague introduce herself as well.
Thanks, Sesona. So my name is Tanya Robbertse, and I'm a research coordinator at Reproductive Health. And I work with Sesona at our Africa region office in Johannesburg.
You know, it's good that you guys are saying sexual reproductive health, but someone sitting at home does not understand that because, you know, we speak in very different dynamics of languages. But what is sexual reproductive health?
So sexual reproductive health and rights refers to both the medical and social aspects of a healthy reproductive life. So that includes access to services such as contraceptives, pregnancy care, and treatment for sexually transmitted infections, but it also includes access to healthcare information. And sexual reproductive health is a human right, and that is how abortion comes into play as well, because abortion is healthcare. And abortion grants people the ability to decide if they want to have children, how many children they want to have, and when they want to have children. And at our organization, at IBIS, we work to ensure that women have that ability to access abortion across the world.
Then how does safe abortion services fit in this framework of sexual reproductive health?
So like Tanya mentioned, sexual and reproductive health and rights, they encompass abortion, right? Because it is one thing that helps young people, or people in general rather, to be able to know or to decide when they want to have children, if they want to have children, and how many children they want. We have some interventions that make sure or that advocate for access to safe, high-quality abortions, but also information to these or about abortion. And I think I'll just leave it at that. We can discuss more about those interventions later.
What are the different types of safe abortions are available?
That's a good question.
How does it work? Yes, how does it work? I think that's also one of the things. We may speak about the different types of safe abortions that are there, but how does it work?
So the main types of abortion, there are two types. It's medical and surgical abortion. So medical abortion usually involves taking pills, either a combination or one of misoprostol and mifepristone. And those medications stop the pregnancy from continuing, and it enables the body to get rid of the pregnancy through contracting the uterus. And that type of abortion is usually within the first 12 weeks of pregnancy, and it's accessed either at a clinic or at home. And then we get surgical abortion, which is a medical procedure that is performed by either a doctor or a nurse, and usually at a clinic or at a hospital, and that is usually within 13 to 20 weeks of pregnancy. So those are, for safe abortions, we generally find different methods of accessing. So the most important thing is that people have access to the correct information, which you can generally get through a healthcare provider. And then, I don't know if you want to add on the difference between like safe abortion and...
Yeah, I think so. I think we can talk about that later.
Okay.
Okay, then we know that in South Africa there's a lot of misconceptions, like myths and all that. And what are the myths and misconceptions that are there that are actually, that you guys have literally came across mostly as a South African context?
We have quite a bit of research on the misconceptions and myths that exist around abortion, which I think Tanya might be able to provide more examples of that. But I think what is more important to focus on or to address is where that is coming from, the misconceptions and the myths that are where they're rooting from. And that's from a lack or a gap in information, comprehensive information on abortion and what rights exist for young people and for everyone in general in South Africa. And so that gap sort of turns into it snowballs. It has a snowball effect into an information gap that results in stigmatizing the issue of abortion, resulting in myths and misconceptions that exist. And that's why it's always important to make sure that people in South Africa have access to comprehensive information, because when they don't have that information, or they don't have comprehensive information to abortion or about abortion, then they can't fully access their right to safe and high quality abortions. And that's why it is important to have interventions that we do have, that we work on at IBIS. One such intervention is the Moho Sexual and Reproductive Health Helpline, which helps young people access information. They can call into the helpline and ask for information about abortion, but they can also find out where to access abortions in their nearest or the nearest facility that provides abortion. But yeah, in terms of misconceptions or myths, I don't know, Tanya, if you have some that you have read in the research.
So we've come across quite a few misconceptions in the research that we've done in South Africa. Some of them are that people believe that if you're married, you need your spouse's permission before you can have an abortion, or if you're below the age of 18, that you need your parents' consent. Other people might think that if you have an abortion, it affects your chances of falling pregnant again in future. And there's also a belief that you need a specific qualifying reason before you can have an abortion. And all of these are untrue, because as we've discussed, in South Africa, you can access an abortion up until 12 weeks upon request. There's no need for a qualifying reason up until that 12-week point.
And, we are touching in a very also sensitive topic where we know in South Africa it's like people just want to hide it. But now we know that there are legal routes that are there. What are the legal rights that a young person has to actually access, not just a young person, but a person that's just sitting at home, the legal rights for them to actually access this type of services?
Yeah, so in South Africa, we have the Choice on Termination of Pregnancy Act of 1996, and that allows people access to abortion on request up until 12 weeks of pregnancy, and then under certain conditions between 13 and 20 weeks of pregnancy. So it is legal in South Africa. And then in addition to that, our constitution grants people that access to bodily autonomy and health. So abortion is also supported by our constitution.
Since we know that when I said access to services, but we know that in South Africa we've got private health care and we've got public health care. What other type of services are they that actually we know that are available in those facilities, and what differs from both of them?
In terms of what services there are, I think it's always important that people have access to information and seek out the information, because for one, people are looking for different services and different facilities can cater to those services. I would suggest using a resource like self-plug, the Moho helpline. But I think maybe, Tanya, you can touch on some of the differences between private and public facilities.
Yeah, so both medical and surgical abortion are available in private and public facilities in South Africa. But as we know, the majority of the country, over 70%, makes use of the public healthcare sector to access these services. And whether or not you'll access a service through a clinic or through a hospital will depend on how far along the pregnancy is. But usually the clinic is a good touch point for that to be determined. So that's generally where people would go to in South Africa to access those services. Although, sorry, no, I was going to answer your next question.
Okay. But what type of barriers, the main barriers, you know? Because we know there are people who end up, we've got back street abortions that are out there, but what other type of barriers do we have in trying to access those services and health facilities?
I would say, and I don't know if you'd agree with me, Tanya, but one of the things that lead or that cause barriers to access is the information gap that I referred to earlier. Because like Tanya mentioned earlier, our constitution guarantees our right to health and our right to bodily autonomy. That includes safe and high quality abortion. And then we have the choice of termination of pregnancy. Act of 96 that also sort of enshrines that access. In terms of barriers or more barriers to that, there is something called conscientious objection that, again, is a result of that stigma that's caused by the information gap, that providers at facilities that provide or that are meant to provide termination of pregnancy that leads them to not provide. And these are things like they may have some or other objection based on their beliefs, if I'm correct, and that causes a young person to have to seek an abortion elsewhere, and they have to seek, and they end up going too far. And that can cause one or two things. They have to travel way too far, which they may not be able to afford, or they end up going to a clinic where there is a long wait list, and that causes them to be past the gestational period that abortions can be provided, which is dangerous because it may, not always, but it may result in them seeking a it's called a backstreet abortion, but we prefer the term informal abortion just to remove the stigma from that. An informal abortion or an abortion outside of the formal sector. But again, it's also important to realize that there are avenues that people can follow. There are resources that are available for self-managed abortions where you can access what Tanya mentioned, some of the pills that Tanya mentioned that kind of facilitate that abortion without actually you having to go too far out of your way to fully access your right. I don't know if you want to add something.
Yeah, I think definitely through our research we found a lot of these barriers that Sesona has addressed, like the lack of information and, you know, in addition to conscientious objection where providers aren't willing to offer the service, there's also a lack of trained healthcare providers who know how to provide abortion or termination of pregnancy in healthcare facilities, which means that there aren't always services available in each facility. So you might have to travel very long distances, as Sesona said, to access these services. And on top of that, there's also what we found in our research is a lot of people have experienced stigma and judgment from healthcare workers when they go to access these services. Especially young people face additional barriers. They face judgment for being sexually active and then additionally for falling pregnant and not using contraceptives. And this discourages them from using these services in the public healthcare sector.
Then right now, probably, I don't know if you know that the data pertaining in your research, what is the scale of people who already now have been trained pertaining abortion in South Africa?
That's unfortunately something I don't have the data on. But what I can say is that termination of pregnancy is what it's called. That training is not included in the medical undergraduate studies. It's touched on, but the actual procedure is not covered in detail. And especially for nurses and midwives, that's also something they have to opt in to do after their studies. So yeah, it's a smaller percentage than we need, and especially for that second period of abortion from 13 to 20 weeks, it can only be done by a doctor. So unfortunately, midwives and nurses aren't able to provide that service, which makes the pool of providers who are able to provide it even smaller.
Then we know that we've got so many beautiful policies in South Africa, but from your guys' context, what should change in the policy to be able to make it better for a certain young person who's out there that needs this type of services?
Yeah, I would I would say that we have fantastic laws and policies. Our abortion law, the Choice on Termination of Pregnancy Act, is sometimes referred to as the most liberal abortion law in the world. But the problem is the implementation, as you said. So we really need to focus on strengthening the healthcare system to be able to provide the services that are there on paper, so that it doesn't just stay on paper and becomes actionable, so people can access these services. I don't know if you want to add to that.
Just to add on to that, what we do, like I said earlier, and guessing we can finally address it, we have some advocacy efforts and interventions that we have in place to address the sort of implementation gap that exists. Because like Tanya said, our policies are fantastic. They are some of the most liberal in the world, but implementation tends to lag behind. So we have the MOHO, Sexual and Reproductive Health Helpline, which it sort of stemmed from, again, our research. We found that young people didn't know what sexual and reproductive health services they could access, and they didn't know that they could even access any to begin with. And so from that, we sort of conceptualized this helpline, which brings together the different services that fall under sexual and reproductive health, including pregnancy, contraception, male circumcision, mental health is also included, gender-based violence, rape, trauma. We have an in-house counselor, and we also have a nationwide database of facilities that provide these services, including termination of pregnancies. We also, in the past 2 years, introduced a advocacy campaign on International Safe Abortion Day. We have marched in different central business district areas in Joburg, where we went around and placed stickers over the posters that were advertising informal abortions. And those stickers have QR codes that lead people to a number of things. There's a link that discusses the guidelines on safe and high quality abortions. There is a link that directs people to the CTOP Act, as well as a link that has a database of, that's constantly refreshed, a database of facilities that provide termination of pregnancies, as well and by stage. So you can contact those facilities and ask them if they can. And again, the MOHO helpline, you can also contact the MOHO helpline and ask for a facility that provides a termination of pregnancy in your area by telling the agent where you are, and they can direct you to your nearest clinic or facility of your choice that is close by. And so these are the ways that we sort of try to address or redress the implementation gap that exists to sort of ensure that people have or can fully access their right to abortions.
Then here's one thing. I'm a young person who's sitting at home, and I want to advocate for such an issues like you said, MSM, gender-based violence, abortion, safe abortion, teenage pregnancy. How do I start as a young person?
That's a great question.
Maybe the MOHO campaign?
Yeah, we have the MOHO campaign, which again is birthed from IBIS research. It initially was developed to address teenage pregnancy and to reduce teenage pregnancy, because again, it is a sort of known fact that when you provide young people with comprehensive sexuality education, they are more informed about their body and their bodily autonomy, and that tends to encourage healthier sexual behaviors if they aren't abstaining. And so the Moho campaign, we work with young people, we work with organizations that work with young people. We have a network of young people that we work with. If you go on the Moho website, moho.org, moho.org, you can get more information about that. You can also call into the Moho Sexual and Reproductive Health Helpline and get more information about the Moho campaign. You can call 080-001-4597. And this is where you can get more information about how you can get involved in the Moho campaign and how you can get involved in advocating for yourself. You know, we, with the Moho campaign, provide young people with information, not just giving them the information and then just leaving them, but we give them comprehensive information so that they know how to advocate for themselves, but how to actually go into their communities and talk to their young people and or to their peers rather, and help advocate for them as well.
In closing, give me each a nice, profound statement that as a young person or a person that's just sitting there pertaining their sexual reproductive health, what message would you give them for them to stand up and stand for themselves?
I think I'd say that just old classic line of knowledge is power. So the more they educate themselves and knowing their rights and what they're supposed to be able to have access to, that means that when they go to a facility and maybe they face stigma and judgment, they can stand up for themselves and say, actually, I know these are my rights and I am supposed to have access to these services.
I'm going to sound like an echo because like Tanya said, knowledge is power. And the great thing about being a young person in South Africa is that we have these rights enshrined in the Constitution. And so you can't go to a facility that is meant to provide a certain service and they turn you away. You have the right to access that service, and so you have the right to request them passionately to give you or to provide that service to you. And if they don't, you are able to ask them to refer you to a place that does. On top of that, young people have the power. The kids are all right, right? And so if you have the knowledge, you have the power to advocate for yourself. There is nothing wrong with speaking up for yourself, regardless of what people think may happen, regardless. So I think all that to say, it doesn't matter what people think of you. If you have a right to access something, you have a right to request it.
So as they said, you've got a right for your health, you've got a right to stand up, and you've got a right to be able to get the services that you need in private health. Private or government healthcare does not matter. At the end of the day, stand for yourself and ensure where you're going. From a wonderful guest who had to share wonderful, profound information about the research that they have done. And remember that the key messages that actually closed in is like, it's my body, my choice. And remember that I have to stand up as a young person or older person, whoever you are at home that's just sitting there thinking that, you know what, I don't trust the system anymore. Your system is your right, and you are here in South Africa to stand up for what you believe in. But without further ado, Ditokello Tsa Hao, it's your right. And without further ado, make sure that you follow us on all social media platforms, @Senec_trust, and ensure that you call to our call to action number if you want to get more information at 067-267-3103. And ensure that next time when we decide to go back on air, to follow us. Sharp.